and then we'll let everyone in. So we are now admitting everybody from the lobby. As a reminder, this does usually take a minute or two. So welcome to those who are joining. I'll continue to talk for a minute to allow everybody who's in the waiting room to actually join into the main meeting. For those who do not know me, I am Dominic Zerlo, and I'm the Center Director for Medical Cannabis and Psilocybin at the New Mexico Department of Health. We are recording this meeting, and so we do ask that individuals please to ensure that you are using appropriate language for video, because we do post it on our website, and so people of all ages may be watching it, and we don't want to have to go in and bleep inappropriate language. For that same reason, that is one of two reasons why we also keep the video off, just in case somebody has something happen in the background that we would have to edit on out. And that while it hasn't happened in our meetings, it has happened in other meetings. So that is one of the reasons we just have our presenters, the chair, and some of the staff on video. But as many of you know, shortly after I conclude this part, I will come off of video for most of the meeting. And with that, we have Dr. Larry Lehman, who is the chair of this committee, which is the End of Life Care Committee. And so I will now pass it over to Larry. So Larry, it is your meeting.
Great. Thanks, Dominic. Appreciate your help as always. Welcome, everybody. Looks like we have a nice size group today, which is great. The heart of this meeting is going to be our Daniela, our psychedelic death doula, who's going to be really discussing, the role. What does that involve? But before I start, I just want to put it a little bit in the context in case you're joining this as maybe your first time. What our group has been doing for the last few months is really getting like an idea both nationally and locally about different roles, really focusing on like 7 core questions. And so sometime at the end of this, I'm going to go look back on those 7 core questions. But for instance, we had Chris Caldwell, who's the founder of End of Life PC, talking to us. We had Jen Clement, who may be on the call today as well, who's a psychedelic chaplain. Danielle's been kind enough to talk today. James Brown, who's a pharmacist with interest in end of life care, is going to talk about specific issues. The 17th, we're still working out the exact plan, but looks like Jennifer Johnson, who is with the Red Willow Hospice up in Santa Fe, is going to talk about hospice related issues. And then we've just firmed up that we're going to do our first like on-site blended meeting on the 23rd of April at a location that Danielle has been kind enough to set up. It's her office space at the Bioscience Center. So that will be posted, and everyone will be able to access as well, through the Zoom. It's a nice opportunity, I think, for us to have a conversation. Teams is very helpful. It gets us together from around the state, but as you know, it tends not to be a conversation. It's kind of individual people talking. So we're going to try to do that. If there's anyone has thoughts on other speakers to put in, but those are kind of what we have so far. And then we're going to be moving over the next few months to integrating all this and making sort of decisions and trying to send some guidelines for approval. So that's our overview. Danielle, thank you so much for agreeing to come here. It's been fun having Danielle as a speaker because her and I have gotten to talk some and share perspectives. So it's been good to get to talk to you a bunch this week, and excited to hear your presentation.
Awesome. Well, yeah, thank you so much for having me. Thank you to the Department of Health, all of you for helping with the tech issues and everything else to kind of get us up and running. Shall I just dive in?
Please do.
Oh, okay, good. Perfect. So before I do that, I want to kind of take a second and let us all get here and arrive. What we're talking about here isn't just a qualifying condition or one more diagnosis. It's death, dying, grief, end of life, bereavement, mortality. And I would argue these are some of the biggest things that we process and some of the biggest challenges that we face as humans. And so if we could just kind of take a second to set aside your to-do list, set aside the things you have to do after this meeting and the things that came before, and let yourself be present for the next hour or so together, hour and a half together, that very often on online meetings, it's really easy to multitask and be doing lots of other things. And so I just offer you this opportunity to be here with each other now. So with that, I'll get right in. So who am I and why have I been asked to have this conversation with you today? For a little bit of background about me, I started my career as an EMT at the age of 18. So I've always worked in the medical field. I eventually went on to nursing school and became an emergency room and trauma nurse in California after graduating from Cal State Hayward with my BSN. And then in 2013, I myself got really sick, spent a long time in the hospital, lots of major surgeries, dialysis, sepsis, resuscitation, all culminating in a near-death experience. And it absolutely shattered my view and paradigm of the world. Took me several years to kind of process that experience and integrate it. And eventually what I came to is that I'm here to be working in end-of-life care and helping people through this process. And so I do that in a couple of ways. In 2022, I opened my private practice, Conscious Crossroads End of Life Services, where I work with clients through the entire arc of end of life care. I use the titles End of Life Guide, Death Doula, and Pure Grief Companion. End of Life Guide meaning that I work with folks that are young and healthy and death is way off in the future. And we're just doing planning and kind of getting their ducks in a row and processing death fears. And then as a death doula, I work with people who are at the stage of palliative care, hospice, active dying, death. And then as a pure grief companion, I help their families and those left behind through the journey of grief. And I use the title Peer Grief Companion because I'm a peer. I am not a licensed practitioner any longer. I do not hold an RN license. I'm not a therapist or a social worker. I am just a peer who has received lots of training in grief, both formally and through lived experience. And so I companion people in the process of their grief. Last year, I founded the New Mexico Death Care Network, which is a new nonprofit here in our state that kind of serves two purposes. We're a professional membership organization that brings together those that work in end-of-life care. We offer networking opportunities and education and things for each other, support there. But then we offer an opportunity for community members to find those services through our website. And then for those that can't afford and non-medical comprehensive end-of-life support like that of a death doula, we will actually pay for the provider directly for those that can't afford the services. So say someone needed a death doula, they can't afford it, we pay the doula directly. So we're effectively keeping good providers in the field while offering services to those that can't afford it. And I'm telling you all of this to let you know that I'm not an outsider looking in on this program or on this topic, that I'm somebody who will likely be boots on the ground working alongside licensed clinicians helping implement this program. And so I think it's important that you understand a little bit of background about who I am and why I'm talking about all of this. So today, what I hope to cover is first, what's a death doula? I think many people on this call understand the role and the scope and the distinction of death doulas from clinical care, but I doubt everyone does. And maybe some who listen to the recording later won't. So I want to make sure we cover that first. And then I want to cover the case for death doulas being included in SB 219 and the implementation of the program. Why psilocybin needs continuity providers such as death doulas. I'll also offer kind of a model of care, like the doula continuum. It's something that very much mirrors how doulas work with folks at end of life and how that can kind of seamlessly weave into the arc of care throughout a psilocybin preparation, dosing, and integration experience. And then there's some kind of hard questions that I think are really important to acknowledge and talk about, specifically scope, licensure, liability, and safety surrounding bringing in additional supportive roles that are unlicensed like that of a death doula. And then some practical considerations that I'd like us to kind of chat about today and maybe questions we can bounce back and forth and things to continue kind of noodling on as we move forward. So first, I want to acknowledge that this is not anything new. Not everybody is familiar with death doulas, but this is an ancient tradition, and this is just the modern resurgence and kind of the modern iteration of it as becoming a profession. Um, Indigenous cultures have held positions such as a death doula forever, right? Medicine people, elders, wisdom keepers, curanderas, shamans, every kind of iteration of this possible. The word doula itself is ancient Greek, and it means a woman who helps or serves, or one who mothers the mother. So very often you hear about doulas in terms of birth or lactation, or postpartum doulas. And death doulas use the same title because there are so many similarities between birth and death. The way I like to explain it is that all of the work and the effort and the pain of laboring life into the world falls on our mothers. On our way out of the world, all of that work and that effort, that labor process falls on us. And so very often the same work and preparation, that you want to offer for a woman doing the hard work of bringing life into the world is the same type of preparation and environment that you want to create for a person who's doing the hard work of leaving the world. And so doulas work in kind of multiple areas. Emotionally, we're helping people hold grief and fear and process anticipatory loss. Existentially, it's talking with clients about life reviews, right? What's the theme of your life story? What has all of this been about? And how can we maybe document it through something like a legacy project or letters to your loved ones? Relationally, families preparing for folks stopping treatment or maybe entering hospice, having difficult conversations amongst family members where maybe values don't match up. That's a lot of what doulas do, advocating for our client, the person who is dying, and making sure that their wishes are heard amongst everyone in the family or in their system, their care circle. And practically, it's a lot of helping navigate through the entire process and journey of end of life, making sure that the paperwork is done, all of the boxes are checked, what I call the business of death, that your advance directives, your will, your trusts, your beneficiaries, and transfer on death forms, all of those things are taken care of. And the after plans as well, right? What do you want to happen to your dead body? How do you plan for your memorial? What ways can we honor you that are unique and important to you and your family? And so doulas kind of work in all of those areas. And there's often a lot of overlap between clinical roles or between hospice roles and what a doula does. A doula does some of the things that a social worker might do. They have some of the spiritual conversations that a chaplain or spiritual advisor might have. Sometimes a doula will sit and offer some respite care so that a loved one can go out and go to the grocery store, similar to what a hospice volunteer might offer. And so there's lots of overlap there. And I think the distinction is that doulas are the same face, the same continuous person through the entire journey with a client and a family. And that's really important to those who are going through such a scary and profound time. So it's important to note that doulas are not clinicians. And when I say clinician, I'm not just talking about physicians. I'm talking about any licensed practitioner. So social workers, therapists, counselors, nurses, physicians, nurse practitioners, PAs, everybody in between, right? Licensed clinicians. So we are not that. We are continuity providers. So we hold the whole arc of before, during, and after a clinical intervention, or before, during, and after a death, right? The preparation, the actual vigil time, and then grief support afterwards. So doulas are kind of primed to be that continuity piece throughout a medicine or psilocybin experience as well. So the licensed clinician is primarily there for episodic care, right? There's preparation sessions, the dosing session, integration sessions, where the doula may be there for continuous care. I've had clients that I've worked with for 18 months before they passed away, seeing them weekly for a couple of hours a week, and that time actually increasing and then actually being there through the death itself. A clinician may be focused specifically on the psilocybin experience and what that may offer as a clinical intervention for an end-of-life patient, where the doula will be focused on the entire end-of-life journey of not just the person dying, but their family as well. The licensed clinician is primarily there with clinical responsibility, and they hold that liability, where the doula is there more relationally, working more on existential and psychosocial support. The licensed clinician will be bound by the program structure and Department of Health rules, as well as their scope of practice legally within their licensure. And a doula's got a more flexible home community-based presence. It's kind of a paid friend, if you will, someone to be there through the entire arc of the journey with you. And obviously a licensed clinician has got their medical or psychological training requirements. And we need to kind of talk about what the requirements may be for a doula in this role. As far as just out there working as a doula, there are many training programs and certification programs out there. So do we need to look at accrediting specific doula training programs? We need to kind of talk about what that will look like for us. But right now, it's generally there's some sort of end-of-life training in addition to lived relational experience. And that's a huge distinction between doulas and licensed clinicians. So I think it's really important to acknowledge like what a landmark piece of legislation SB 219 is. The fact that we're only the third in the country that's working on this psilocybin, Medical Psilocybin Act, period. But we're the only ones that have the end of life care provision in here. However, it's not defined about what exactly that means. It's kind of up to the Department of Health Advisory Board to come up with the definition of end of life care and who those patients are, what that timeline is, and what that looks like. And so we have this really great opportunity because within that, that means we also have to define what the care team is composed of and what that looks like, what support roles are open. And so I think it's really important now that we name the role of the death doula or the end of life doula, because if it isn't named in the rules, it effectively doesn't exist in implementation. Systems tend to default to what is actually written in words. And so I think it's important that we define it now, both in what the role is and what it is not, so that it's covered and that there's clarity and recognition of the role, boundaries around the role, and that will lead to safety. There we go. So this is kind of that doula continuum of care that I was talking about. And you can kind of overlap this arc of care with the actual dying process itself. Here we're looking at working within a psilocybin program, but I would argue that death itself is kind of the ultimate journey or the ultimate ceremony, and that every other medicine experience that one has prior to death is prepping us for that one. And so this whole arc looks exactly the same, whether we're talking about a medicine experience or the actual dying experience. And so the before, doulas help again with life review, legacy work, lots of questions like, what's the theme of your life story been? What are you the most proud of? What are your biggest regrets? Diving into that and finding places and ways to acknowledge that story and memorialize that story for people through legacy projects. Where a clinician may come in and have a diagnosing tool that they can use, a clinical tool that will help them determine, yes, this person is experiencing existential distress or death anxiety. And it's a box that is checked, a code that is put into a system in order for a reimbursement. But a doula will be the one sitting there walking people through meditation exercises to help process that fear of death. The one holding their hands through the actual death process itself. So there's a lot of fear and meaning making processing that happens on the prep side for doulas. Intention setting versus clinical goal setting. is big. How do you intend to feel at the end of this process? What are your goals there instead of just a clinical goal? We can also help prep family, right? Explaining to family that your person is likely to come out of this experience different, and how that may look in your relationship and in their processing of their experience moving forward. And then also making sure that we're bringing cultural and spiritual context to everything. Um, and that's different for each person. Doulas are specifically trained in meeting people where they are and honoring their cultural and belief systems as they are, without influencing them or bringing our own stuff into the picture. During the experience itself, doulas can be a trusted and familiar presence, because again, we have likely been with this family and with this client through the process of even determining if they want to seek out a psilocybin experience, and then helping them find a practitioner to help them through the process. So we can be a very familiar face in an altered state, which can be extremely helpful. Again, we're already trained in the non-clinical vigil support, and in my experience, facilitating a deathbed space, a deathbed vigil, is very similar to holding space and supporting someone through a medicine experience. Again, this cultural and ritual holding is something doulas do all day, every day. That's kind of our bread and butter. Offering comfort and grounding cues, which are again are often the same types of cues that are offered during actual active dying time as well. And again, just having continuity through the altered state, that familiar presence. After, for integration, helping translate these insights into action, where very often you may receive some sort of insight that now it's like, oh, I need to repair my relationship with this person. A doula may be there through the entire process of what that looks like for this person and this family. And now maybe the reintegration of a family member into the family system that might happen, say, at the deathbed space. And a doula may be that continuous person there that's through the entire process with that family. So translating the insights that you receive into action in your life. How does it change how you process your deathbed experience or your relational experiences with those around you? And again, legacy project support. It's not just about saying, yes, legacy projects would be good for you. This is something I recommend you do, but actually actively helping clients do those projects. Helping again with family debriefing, just being there through integration processes with the clinician and then continuing that afterwards. And again, that continued emotional processing over time, because we're likely to be the ones continuing the relationship through death. And then beyond the psilocybin experience itself, but at active dying time, what better source of comfort than the person who was also there with you during your psilocybin experience is now that same energy, presence, and face that you see as you're actively leaving the world. Doulas are also great for family bereavement care, as I've already mentioned, and post-death guidance, guiding families through ceremony and ritual in the presence of their loved one's dead body, spending as much time as they may need. That can even look like holding home funerals. So many different things that doulas can offer in the post-death space. And then again, just community grief support. So doulas in the preparation section of this process, I guess that you could call it, I think are extremely important. We're all very aware that psilocybin outcomes are completely dependent on set and setting. And doulas are trained in this terrain. That's exactly what we do, is set, and setting. We have been trained to treat death as a sacred event. And so setting up everyone's mindset of how they enter that deathbed space is very similar to how you set up someone that's entering a psilocybin or a medicine space. Again, talking about life review and narrative reflection ahead of time, processing fears and helping people let things go, helping them articulate their intentions, not just their goals, helping prepare family for possible psychological and spiritual shifts, and really important is the cultural and spiritual context setting. Jen talked about this a ton last time. And I think that's absolutely key, especially in the end of life space for folks. So as far as the policy goes, this is important because it'll help improve safety and reduce risk of distress during the sessions. Because again, there's been this continuous person that has helped them walk through all of this prep beyond just that 1 or 2 sessions that may be covered under the program itself. And it extends beyond what clinicians actually have time and bandwidth for. Just like all parts of our medical system, palliative care, hospice care, that those medical teams are stretched incredibly thin, and they don't have the space to see clients for extended, long preparation and integration sessions before and after a journey. And so we can also kind of help be eyes and ears to help the clinical team assess cultural gaps, things that we may be missing because, again, the clinicians and the medical team don't have the time to spend that a doula might. And then this reduces the burden on licensed facilitators and clinicians. So if doulas are working alongside licensed clinicians, that combination can offer so much more to a patient and a family than just the clinical process of medicine. And so I think integration, again, is where doulas can be the most essential. If we only treat this as a clinical intervention, it will be effective. And we will miss out on a lot of opportunity for the patient and the family. Without long-term integration, the insights may not translate into actual action. And so what doulas can do is help, like we said earlier, actually move things into real life concrete actions that make a difference in how they not only live the rest of the time they're here, but what their death looks like and how their family ends up processing the grief afterwards. So the key distinctions from clinicians where we're translating insights into end of life decisions, it's not just the psychological processing, it's the real life. Yeah, I keep saying it, but the real life concrete actions. And we can also help support and repair of relationships, and that presence extends to active death and bereavement. We're holding those legacy projects through to completion so that they're actually delivered to family members before or after the person dies. It is non-clinical. We are not diagnosing, we are not treating, it is non-directive. We help bridge the mystical experience into practical life closure. And so again, it's relationship-based over time. It's not episodic. So it's not just coming in for a clinical intervention. It's continuing throughout the entire arc of care. Another big thing to talk about is that, especially here in New Mexico, we've got a very large rural population, a large indigenous population, and a large low-income population. So doulas can help extend the reach of the program. Excluding doulas risks creating a program that's clinically sound and socially inaccessible, which is unacceptable. That was a Freudian slip. It's always been a big challenge to me that even doula work is something that very quickly could become only available to a small percentage of the population. And I think all of us in this room are really aware of the fact that psychedelic work and psilocybin work is very quickly kind of becoming another one of those things. So bringing doulas in can kind of help mitigate some of that risk. So we can be community navigators for rural New Mexico patients. So people that are way out that may have a hard time waiting for a clinician or seeing a clinician on a regular basis, perhaps there's a doula in that area or a doula willing to travel to that area, and it would be much less expensive to cover that cost. We can also work as kind of cultural translators and navigators between indigenous communities, which are very often these low-income rural indigenous communities have very good reason to be distrustful of medical systems. And so having a lay person, someone outside of the system, helping navigate and translate can help kind of bridge that gap and increase trust and comfort with the system. Again, using plain language and informed consent types of support, which lowers the barrier of access to the program. And doulas also help extend family and caregiver support. Doulas are specifically trained to not just work with the person that's dying, but their care circle as well. That's part of what we're taught to do from the very beginning. And so we can help prepare families for the client or patient's possible changes in worldview, um, helping them interpret their loved one's experience. Um, we are experts in helping reduce caregiver anxiety and confusion through a sense of grounding support, but also education. I think education is absolutely key to reducing anxiety throughout the end of life process, both for the person that's leaving and for their care circle. And then we're also, again, already trained in facilitating these challenging conversations that may come up post session. Um, and then again, we can provide bereavement continuity. I find working with my clients that they find a lot of comfort in talking to me about their grief because they know that I knew their loved one. And I may have even been present when they took their last breath, which can feel incredibly supportive to someone as opposed to coming in and talking to a complete stranger about someone that you've lost. So kind of the harder questions and the things that I think that are really important to acknowledge and that are really important for me to kind of help us tease apart and figure out, coming from a medical side of things, coming from a career where I was licensed and I was in a regulated industry, it's really important that we define the role of a doula within this program. And so some of the concerns are scope creep and clinical overlap. And so a proposed safeguard there would be that we explicitly define the non-clinical role of a death doula. Again, what we do and what we do not do, what is permitted and what is not permitted. The fact that we are not licensed as doulas. And I don't think I mentioned that in the very beginning. I apologize. Doulas are certified through whatever training program that they took. There is currently no overarching regulatory body or licensure for doulas. It's almost similar to a life coach where almost anyone can call themselves a life coach. So it's going to be really important to put in place some competency-based training requirements and some sort of a voluntary registry of these folks that have gone through whatever approved training programs. There is some precedence for this, and we'll talk about it a little bit more later through birth doulas, where there are multiple different tracks through which they can be certified in order to receive reimbursement through Medicaid. And we'll dive into that a little bit more in a moment. There's also some overlap with the role of the clinician, the licensed practitioner here. And so again, it'll be really important to clearly differentiate in our language the role of the clinician versus a doula or non-licensed support person. And the fact that the clinician's role is generally episodic, where this non-licensed support person, the death doula, is a longitudinal relationship that continues throughout the entire arc of end of life. Concerns around liability and accountability. Again, it's going to be really important to make this a team-based care model so that the non-licensed person is never working on their own or facilitating on their own, that they are always working either under or alongside a licensed clinician, that it is a team-based model, and that there's very clear informed consent language throughout. And then the other big concerns are patient vulnerability and safety. And again, that supervision coordination with the care team will be really important, but then also having some sort of escalation protocols in place. You know, if something did go wrong, where does the community member go? Where does the patient complain to, kind of thing? Because again, if there's no overarching regulatory body, there's got to be some sort of oversight in place. So doulas are not new to healthcare adjacent roles. There are lots of established, unlicensed, non-clinical roles that are well accepted in healthcare and reimbursed through healthcare programs or government programs. Lots of examples listed here: community health workers, birth doulas, peer support specialists, and patient navigators. Using peer support specialists as an example, those are folks that are lay people who have generally gone through something themselves, either substance abuse and recovery, or mental health issues and recovery there. And then they go through a 40-hour training program where now they can go out and support people who are going through the same types of issues that they've already gone through. And that role is state recognized. There's a competency-based credential and a listing of those folks. So I can see death doulas ending up in a very similar situation. Or for example, birth doulas are currently covered by New Mexico Medicaid and several other states. And there are very clear tracks for their certification for reimbursement or for eligibility in that program. There are accredited training schools that you can choose to have gone through, and that's one of the tracks for certification, or for eligibility rather, for reimbursement. There's also a, kind of a community member, like a folk healer sort of person that has been doing this for years and years and years, and a licensed clinician just writes a couple of letters of reference. So there are different ways of not certifying or creating eligibility or acknowledging that these people have received the competency-based training that's necessary. We've tested them in it, and we acknowledge that they are acceptable to go out and do this work in the world. So we don't have to reinvent the wheel. We can look to a lot of these other unlicensed roles in healthcare to figure out exactly how to do this with death doulas as well. I'm going to go over this slide really quickly, but my whole point here is that there's lots of evidence that psilocybin is helpful at end of life, right? We've got the NYU and Johns Hopkins trials that show significant reductions in death anxiety and depression. Dr. Lehman's done lots of studies, currently working on lots of studies. There's tons of evidence that it works and that it helps. There's also a fair amount of evidence out there at the moment, not enough studies have been done, but that death doulas also do something similar, that there's an improvement in quality of life, reduction in anxiety, increased sense of control for the dying patients, consistent evidence that there's benefit to family and caregivers. And the point is that here in New Mexico with this program, we have an amazing opportunity to show, if we collect the right data, the evidence that bringing these two modalities together, what death doulas can offer at end of life, along with psilocybin experiences, then what can we bring together to show that, what evidence can we collect to show the benefit of bringing these two to dying clients? And I think the evidence will be really clear very quickly, just in what I've seen personally, anecdotally. And so I want us to kind of just pay attention to that and to kind of maybe think about what data we can start collecting now. We're in a really amazing position here, so I don't want to waste it. So these three practical considerations moving forward. Everything we've talked about so far has just kind of been context, but what do we do with that? So we know what death doulas do. We know kind of how psilocybin can help at end of life, how death doulas can help at life, and then what? So again, recognition creates clarity and clarity creates safety. The first step, I think, is defining the role of the doula in this setting, that it's non-clinical, non-directive, non-licensed end-of-life support. And that we should be a permitted presence throughout the psilocybin experience, as long as that's what the client/patient wants, and at the clinician's discretion as well. But that we're there for the preparation sessions, we're there during administration, we're there for the integration sessions, and we'll likely be the ones that are there at the deathbed vigil, where the clinician likely won't be. That's just not generally how it goes. We need to define explicit boundaries, right? What the doula does not do, and it's not permitted to do, that there is no clinical assessment and diagnosis, there's not psychotherapy, there's no medical care, there's no administration of medications, on and on, right? That's all explicitly laid out. And then there's got to be coordination protocol and required communication with licensed clinicians on the care team. And then I think we need to create a lightweight doula participation pathway that it's got a low barrier to entry, but is very clear, good boundaries, that it's not licensure, because that will limit access and exclude workforce diversity. So there needs to be many minimum training criteria. We've talked about that a little bit. There are multiple doula training programs out there. And what type of specific psychedelic psilocybin training do we need to require for our doulas in this role? That we need to create some sort of a voluntary registry system, similar to what we've got for community health workers. We need to form a code of ethics around death doulas in the psilocybin space. One of the things that we can look to here is the National End of Life Doula Alliance, or NEDA. They do offer a professional membership organization for end of life doulas, and they do offer a short exam that one can take and get a proficiency badge, so that it at least says, I understand the scope of practice, I understand the legalities surrounding my role, I understand, cultural competence, the basics of what it means to be a death doula out there doing this work in a safe manner. And so do we create something similar, right, where there's a testing system and a certification that says that, yes, I understand all of the roles of a doula and as psychedelic support person, and I'm approved to do this work in New Mexico. And then again, creating accountability mechanisms. Obviously, any doulas working within this would have to agree to whatever the program guidelines are. I think we should have background checks there. Grievance processes need to be put in place, and that all of that needs to be proportional to the non-clinical role. We need to recognize that we can't be charging doulas $10,000 for training programs when they're never going to recoup that ROI based on what they can actually charge clients. So we need to be realistic about what we're asking of people in this role as well. This one, this is more just kind of me and my ideas, and I want to throw all of this out there, but I think it's really, really important to note that equity is not just access to the substance or the medicine itself. It's access to all of the support that makes psilocybin meaningful and safe, and that will actually result in concrete action and change for this human in life and death. So we already have the Treatment Equity Fund. Dr. Lehman and I talked about that a little bit, and that's kind of been set aside specifically for the medicine, and that's great. What other funds or what other systems can we come up where we make doula services explicitly eligible? Is there a per patient stipend that helps enroll doulas within the program that prioritizes rural and low income underserved patients? I just want us to be open to thinking about what something like that might look like. And then I think pilot programs and grants, like there's something for the research fund already, including doula integrated care models in our pilot research, and then tracking specific outcomes, right? Was there an improvement in death anxiety with a doula versus without a doula, or before the doula versus after the doula was brought in? Same with family satisfaction scores, care utilization. I think that if we did some good research, we would likely find that there are a lot less utilization of even the hospice nurses and hospice resources when you have a good doula relationship in a family as a person is dying. And then for the concrete kind of action steps, does it help once you bring in someone like a doula, or you've had this psilocybin experience? Do people get their paperwork done? Do they do their advanced care planning? Do they get their most finished and their wills done? Because they now have this different level of acceptance of their own impermanence. So I think examining some of those things and making sure we have some funding for that research would be really helpful, and including doulas in some of those metrics. And then bundled care models. Do we start to include doula services as reimbursable support? There's precedents already for this for birth doulas. I think death doulas are probably 20 years behind birth doulas as far as getting policy in place and lobbying and all of those things. But again, we're in a really unique position here with this program. So could this be a pilot for the rest of the country? Some of the metrics, like I mentioned earlier, that I think we should kind of be looking at: patient death anxiety scores, completion of advanced care planning, family caregiver satisfaction, psychological distress post-session, program access by demographic. I think this is going to be really important for us to pay attention to. Is this only being utilized by upper middle class people in the central part of the state here in Albuquerque, or do we have real access and real utilization by our more rural, indigenous, and low-income communities? And then care coordination and quality, the doula clinician team communication. So that was a whole lot of stuff. But to just sum it up really clearly and really succinctly, I think as doulas, what we're kind of looking for within this program is that, number one, we define the role so that it is acknowledged within the program, that it gets implemented, and that it is safe. That we create a pathway for training and oversight so that we're accountable and accessible. And then there's got to be some sort of funding of the role, because the reality is if we don't include that somewhere along the line, it's going to turn into asking doulas to volunteer their time. And that just becomes exploitative over time. It's just one more way of, not honoring the caring, nurturing, non-licensed roles in our society. And so to kind of sum up everything that I'm kind of trying to bring here is that if this program is only designed around the clinical moment, it'll definitely work. There will be positive outcomes for people, no doubt. We know that about psilocybin in and of itself, but it will only partially work. If we include structured non-clinical care like death doulas, this program has the potential to not just transform how we experience medicine, but how we experience dying. And how we experience living the last however many months we have on this planet, if we're in an end of life spot. So with all of that, I am here for questions. I hope that sparked a whole lot of questions and a lot of conversation. And my contact information is there. You can get me through either one of those websites, and I hope we have lots more to come.
All right. Thank you, Danielle. Larry, did you have anything to say before we take some questions for attendees?
Yeah, yeah, Danielle. First of all, Danielle, that was a great talk, and even having seen your slides and watched it another time, it was really great. So I really appreciate all of that. I may have one or two questions. Maybe I'll pop in before we open. One is, and I hope this isn't too specific a question, but as we're looking at like the finances of what would it cost? I mean, how does it work? I mean, in other words, you obviously when people hire a death doula, they don't know how long they're going to be living for it. How is the billings done? And if we're thinking about trying to get that covered.
Yeah, so as far as working with a doula in their private practice, every doula does it differently. And so everybody charges a different amount. Some people will do it hourly, some people do it as a bundle or packages. I personally offer either an hourly rate, or you can purchase a bundle of 10 hours up front for a discounted rate. And then once those hours are used, we continue at the discounted rate. Now, as far as how we reimburse through the New Mexico Death Care Network, because we have limited funds, we have a very nominal hourly fee of $50 per hour, but each provider can be reimbursed at $50 per hour for up to 30 hours per client and 2 clients per calendar year. That we hope will offer a good amount of supportive time for a client and a family. That likely will not cover all of the hours all of the time. And it's a nominal amount, $50 an hour. But it's what we can do at the moment. And it's also modeled after the reimbursement program for birth doulas, where birth doulas are allowed up to $1,500 per patient through a birth doula, like through a labor delivery process. So we tried to kind of model things that way. And I think that we can look to that reimbursement program and do something similar.
Danielle, why only 2 clients a year? Like, what's the rationale behind that?
Trying to limit so that one person isn't taking all of the funds, because the funds are so limited. We are currently only, we're completely privately funded. We haven't received any grants or anything yet. So we're on a very limited budget. So that was the rationale. Hopefully we'll be able to open it up to make it unlimited someday.
And then Another question is, and this will come up in other meetings. We've talked about this is end of life care, but that having an expansive care on that. In other words, you could be diagnosed with, stage 3 breast cancer and have a, estimated lifespan of 2 years, but you're still in a grieving process, and that end of life care with psilocybin therapy would be appropriate. I'm curious if you think there's any role for a death doula and somebody in that situation.
I think absolutely yes. I work with clients at all different ages and stages. I have several clients right now who are undergoing treatment, right? They've just gotten some sort of diagnosis, and those folks would be absolutely prime for a program like this. Helping them process their diagnosis, their treatment, what it means, like how to work with their bodies, all of these things could be extremely helpful for those who are just diagnosed and not at end of life yet. And then as far as grief goes, I think that after an initial period of time, and that time will be different for every human, there's no prescribed time that's correct. But after a time of initial processing and fresh grief, and you've kind of moved through some of those very natural organic stages, I think that a psilocybin journey and experience can be incredibly helpful for people continuing to process grief.
Yeah. One more question, then I'll quit asking questions. Do you think that we should be requiring that at least for reimbursement or involvement, that the death doula has passed the NIDA exam? Is that like Jen mentioned that in her, I wanted to see what you thought about that. And also what's involved in that. You mentioned that we don't want people to have to spend a $10,000 program.
Yeah.
Is the NIDA, what's involved in like studying for the NIDA exam and taking it?
It's a fairly short exam. It's a pretty simple for the most part. I think it was 100 questions or something like that. Really nominal fee. I think it was a $50 entrance fee, and then their membership is $50 or $100 a year. So again, it's very nominal prices. They don't offer a specific training school. NIDA does not. They just offer this proficiency exam. And since they are the closest thing we currently have to a regulatory body, right? They're just a professional membership organization, but they've kind of taken up the lead for establishing codes of ethics and scope of practice. And so they are the best we have at the moment, for sure. And so in short of creating our own testing and licensure or certification system, yes, I think that they are a great place to start, is requiring at least NIDA proficiency.
Danielle, thanks for answering all my questions. I think we have a
Thanks for good questions.
few other people's questions. Thank you.
All right, sounds good. We will go to the attendees. And again, for folks who would like to ask questions, there is a icon in the top left part of Teams that says raise, that has a little hand. And you can go ahead and click that if you'd like to ask a question. So it looks like first we've got Hannah Rose. And Hannah, I have enabled your mic. You can talk when you're ready.
Yeah, I believe. Oh, wow, my hand was raised. I did not mean to have my hand raised because my questions were pretty much answered in the chat. So, yeah, I was just curious about dual roles in the program as a death doula and as a clinician, and then once I have my social work degree, then also as a social worker. But that will be clarified in the future in other meetings. Thank you.
Sweet, thanks, Hannah. Oh yeah, and I guess other reminder for folks, if you could also just like introduce yourself, and if you're a resident and have any affiliations as well. And so next we have Clifford Rees. Clifford, I have enabled your mic. You can unmute and speak when you're ready. Oh, and again, to do that, the mic icon is at the top right part of the banner in Teams. If you click that, you should be able to unmute.
Got it. Yeah, and my raised hand is on the upper right too, not the upper left, but that's fine.
Ah, okay.
I'm still learning. 6 years after the pandemic. My name is Clifford Reese. Introduction, I'm a retired Department of Health attorney, spent 23 years with the department, left the department in 2004, but worked on medical cannabis in 2000 through my departure from the department. The last 20 years or so, I've worked seasonally during legislative sessions for the state legislature, and in particular, I was Senator Jeff Steinborn's legislative analyst during the 2025 session when the Medical Psilocybin Act was passed. I have two observations, if I can call you Danielle. Excellent presentation. And I'm coming from the legal perspective, so this is not meant to be criticism, but one is a suggestion for all of us, and I hope the staff is listening. I don't give legal advice to the Department of Health staff anymore, but it's a hard habit to break after 23 years. I would stop referring to the statute as SB, 219, because every year there's an SB 219. I would start calling it what its short title is, which is the Medical Psilocybin Act. And if you want to, we can put in parenthesis, laws of 2025, comma, chapter 73. And this is in the New Mexico statutes annotated, because we're talking about a very specific Senate Bill 219 henceforth. So let's not create confusion. Let's educate the public who we want to reach. And again, this is not a criticism. This is just the lawyer observation. The second part is I have a different interpretation, Danielle, of what you think should be in the rules versus not in the rules. Of course, the statute authorizes the rulemaking process. So statutes have legal effect, just like the rules have legal impact, just like the statute, because it's based on a statute, a delegation of authority in the Medical Psilocybin Act to the Department of Health. And what you presented, as I heard it, and please correct me if I didn't understand you, was you wanted a very detailed rule to cover most of the things that concern you about how the program will be implemented. There's pros and cons to that. The pro is that it's clear what the department intends through rulemaking, which intentionally is not in statute because the department has the expertise, and that's why it has the rulemaking authority to fill in the details. The con is, the counter argument is, if something is not in the rule, then it can be argued that it's not specifically prohibited by the statute or rules. What I'm thinking about, and this is based on my medical cannabis experience, is this field of medicine is changing rapidly. I think we would probably agree, philosophically anyway. And so if we have a very detailed rule and medically things change, the department would need to go back through the legal rulemaking process and amend the rule. If there's a bit of flexibility there, that wouldn't be necessary. And the department could issue policy decisions based on its interpretation of the statute and rule. So it's really a question more for staff, perhaps, Danielle, but that's just how I see it as an over-the-hill retired public health attorney. But thank you very much for your presentation. I have also followed very closely the Elizabeth Whitfield End of Life Act that was enacted in 2019, and I use the short title. And I know my great colleague and friend Barrick Wolf is on this, and he and his colleagues were instrumental in getting that passed. And that really, I think, has opened the door for today. So thank you for your presentation, and I'd be glad to hear your comment or anyone else's comment on what I just said. A little bit windy, but habits are hard to break when you're an attorney. Thank you very much.
Thank you for that. First off, the education on the SB 219 part. I wasn't even aware that changed, and it would be repeated yearly. So thank you for that. That's good for me. Just knowledge moving forward. And yeah, it's interesting, and this has come up for me just recently with even the nonprofit as we were forming everything, and making sure you put enough in your bylaws to be clear, but not too much that it's confining and that back and forth and whatnot. And I think that my perspective came from that place of wanting to make sure that this role is somehow integrated into this program. that non-licensed support people are acknowledged, accounted for, and honored for what we bring to the table. And acknowledging, I think a big part of that is that death is not a medical event. A lot of medical stuff happens around death, and a lot of clinical support and intervention is useful and necessary. But it's a community event. And so how do we make provisions for honoring that part of it in a clinical setting? And I don't know what the right way to do any of that is. And I'm definitely not a lawyer, so I value your perspective.
All right. Looks like next we've got Chris Caldwell. Chris, I have enabled your mic. You can unmute when you're ready.
Hi all, Danielle, that was fabulous. Thank you. This is Chris Caldwell, founder and director of End of Life Psychedelic Care. And some of you know that one of the reasons why I founded the nonprofit was to bring the voices of doulas and chaplains into this work. And so I have a few comments, and I have a question for you, Danielle, or whomever. And I do want to tell one quick story. Okay, so a couple of years ago, we was working with Michael Frack, palliative medicine physician in Northern California, and we paired him with a doula. And one of the stories she shared was that, and Michael is a fabulous physician, but when he left and she was there, and like you're talking about, you build the trust, he let his hair down, so he wasn't talking to the doctor. So I absolutely love the role of a doula. So a couple of other things, just so all of you know what I've been working on. By the way, End of Life Psychedelic Care has the only end of life doula training that has a plant medicine component, quote unquote. It's not a training for psilocybin facilitation, but it does prepare you for the NIDA exam, just like you're talking about, Danielle. And obviously it's not for any doula, but for anybody else like a social worker, therapist, a physician who may in fact want to learn more about end of life processes. So this year we are a group program like Enel does, actually, if you're familiar with that, but I won't go into what that is right now. One of the things we are doing, to your point, Danielle, we received a grant to do home-based ketamine and spiritual care. So this is ketamine, but we are pairing an end-of-life doula or chaplain or minister with a palliative medicine physician. We'll dose our first patient next month. We are building that process you're talking about, and we obviously will have some data. It's only 15 patients that we're supporting under this grant, but by the end of the year, we'll have some data for you guys. And then I think, let's see, I think that's it. The question I have for you though is, when you're talking about a doula being a part of a team, are you talking about in-person supervision by a clinician, or are you talking about remote supervision by a clinician?
I think that's kind of up in the air at the moment. I fully believe that doulas are, with the proper training, perfect people to be in-person facilitators and support people. And a clinician could be doing remote support, that they are there for the prep and the integration and maybe even there remotely. But we've got a lot of really far out rural areas around here, and say somebody, way down in Silver City that's at end of life and homebound and maybe a hospice patient needs these services, it may be much more realistic to count on a non-licensed support person to be there during that dosing session, than having to wait for a licensed clinician. And so I think that that's open to the committee and the board to continue talking about. But again, we're already facilitating these very challenging altered experiences, such as the deathbed space, and we're doing that without physicians, we're doing that without nurses, we're doing that without any of these licensed or medical supervision at deathbed spaces. And this is extremely similar, extremely similar.
Yeah, well, you know, I wholeheartedly support that. And if there's anything I can do to pull it, we've got some data, but from a psychedelic death worker study we did as well. That if you want to set up a time to talk, you also remind me when you were talking about the prepper sort of roles that a doula could fulfill. One of the things we talk about all the time is the benefit of integrative practices, whether that's reishi, you know, for somebody who's trained, but guided visualizations, uh, yeah, like support of meditations, breathing exercises, reishi, gentle yoga, restorative yoga, and stuff. And you know, we have doulas doing that all the time, especially when psychedelics may not be um, called for at a certain stage of life. So yeah, thank you though. Thank you for excellent work.
Excuse me, I would love to connect.
All right. Let's see. It looks like next we've got Clifford Rees again. Let's see. All right, Clifford, I have enabled your mic. You can unmute when you're ready.
Thank you very much. And I thank you for the opportunity to ask a follow-up question. Certainly want people to have an opportunity for their first question. Danielle, let me ask you this. You talked about licensure and lack of licensure. Do you personally favor licensure of death doulas by either the Department of Health or the Regulation and Licensing Department, knowing the hoops that one needs to go through when the executive branch issues a license to practice a profession?
This has been a big topic of discussion and something that I've personally wrestled with quite a bit, again, coming from the more medical side of things and licensure. And the answer is no. I think that the main benefit of doulas is that we are outside of the system. We are supporting the system, we are adjacent to the system, but we're outside of the healthcare and medical system. And that's what gives us our relational power with a family. And it's a different level of trust that can be developed. I very often work with folks that tell me things like, I don't want to tell the social worker this. I don't want to talk to a chaplain, but I'm just a doula, right? I'm just a girl coming in to talk to you. And that allows us to develop things on a completely different level. It also allows us to maintain our role as the client advocate without any sort of conflict of interest. It is always my primary role that regardless of what's happening, say a hospice company isn't working out. If I'm there as the nurse, I'm an employee of this hospice company. Even if I know that we're not serving this person the best way possible, I can't recommend that they seek out a new hospice team. But as a doula, that's going to be the first thing I do, right? Is to get them the care that they need and deserve. And so, having been on both sides of it, I don't think that doulas should be within the system. I think we need to stay next to it and working with it and collaborating with it in order to offer all of the benefits that we can to a patient and family.
Yeah, I understand your point of view, and I largely agree with it. I just wonder when you're talking about Medicaid and reimbursement, whether at least some form of licensure beyond the certification through training would make it easier to facilitate the payment, which is an issue here because the equity fund probably isn't going to cover everyone's expenses entirely. And so other sources of funding may very well be important to ensure the success of this new program.
Completely agree. And that's part of even why I've gone back and forth with the idea of, does it make sense for us to seek out that pathway of reimbursement? Or do we stay private pay, and are we better served to find our own structures and systems for compensation and reimbursement, like I've done with the New Mexico Death Care Network? Because that was exactly my thought, is if we don't create these systems and we don't start taking care of ourselves, by nature, government institutions and bureaucracy will do so. And will they then support us in the role that we're currently in, or will our role have to change in order to fit a system that's already pretty challenged and in places broken. And so yeah, there's so much there with all of that. I would love to keep talking about that specifically with you if we could connect at some point.
All right. And next, we're going to go to Dr. Lita Fatemi. She's got her hand up. And Dr. Fatemi, your mic should be enabled. You can unmute when ready.
I'm so excited for this. It's Dr. Lita Fatemi, as you can see. I'm the founder of the Conscious Physician Psychedelics Academy. I'm also a hospice physician with ABQ Hospice and Palliative medical practice. And I've had the pleasure of getting to know Danielle over the years and working together. And, you know, in fact, I have been a practitioner in the past who have held space with medicine and a death doula at the same time, which was extremely beneficial and supportive. And I'm so for this. I think this is what we need in the care context of psychedelic care. And it's greatly appreciated. And as you said, Danielle, I love that you're advocating not only for reimbursement for death doulas, but really everybody who's involved in this process. It's a trying process for everyone. We all need support in all forms, including the hospice staff. Let's say a hospice company does decide to participate, just like with MAID, and having a death doula alongside you is, oh my gosh, it's quite a game changer. Thank you so much for what you do and how you presented this information. It's beautiful. Thank you.
Thank you.
Awesome. Thank you, Dr. Fatemi. Let's see. So also, Danielle, yeah, if you'd like, I can also just read through some of these things in the chat real quick that people have put in. So I guess starting with after your talk, the first one was from Vanessa C. She just said, medicine work is helpful for the family and community as a whole, as well as when one is facing EOL. And then Gregory Evans said, the National End of Life Doula Alliance, NEDA, proficiency exam typically costs $115 plus an additional $50 for NEDA membership, bringing the total to $165 for the certification process. NEDA also partners with training organizations like Lifespan Doulas, where certification is included in their training course fees. And then going down here, Don Moser says, thank you. I have to leave now, but learned a lot. Let's see. Lisa Jimenez, thank you, Clifford. Jen Clemente had the same takeaway about spiritual care. It's not mandated, but does that risk its non-inclusion? Let's see. And then Vanessa C again. Death doulas act as harm reduction educators, ceremonialists, and peer support. Death is a psychedelic experience. We know how to hold this space with or without fungi medicine. I've been in sessions where the clinician is present for the dosing in the first 15 to 30 minutes in person or virtually. I held the rest of the sessions as the doula. It also removes time restrictions. And then your husband just being a proud husband, which is great. Sky Rivers comments, but without training on psilocybin, do you then offer this to a patient? Vanessa C again, we are better served to stay independent. And then finally, Gregory Evans again, in the context of birth doulas, they are embraced by medical teams and trusted to identify the proper timing and triggers to engage with the medical part of the teams. They are the advocate and trusted to represent the entire community around the person experiencing the process of that transition. In the context of universal healthcare and harm reduction, I would love to see infrastructure that supports those roles financially. All right, and that's all we had in the chat. And I don't see any other hands up at this time. With that, Larry, I'm gonna defer back to you and see how you'd like to proceed.
Can I just hop in quick and just comment quickly on that? And
Yeah.
I'm glancing quickly on, I don't forget already who said it, but the that doulas are already trained to facilitate the psychedelic experience of death, right? And that we do it with or without medicine. And I just thank you so much for the way you said that. That was perfectly eloquent. You said it better than I did. But in my experience, having done both, having participated in medicine ceremonies, facilitated medicine spaces, and been present at 17 deathbeds with the final breath in the last 3 years, it is the same work. And I don't think that there are better positioned support people in this role than death doulas. So thank you.
This is Larry. I'm just trying to do a little bit of a screen share. Let me see if I can get it to show a little PowerPoint here. It's not really essential. Are people hearing me okay?
Mm-hmm.
Yes, we can hear you, Larry.
Okay, good. Sorry, I'm just trying to, I was unsuccessful to get a PowerPoint on there. Danielle, that was amazing. I mean, you could see all the response, really helpful. It feels like we're putting like different pieces of this together each time, looking at the spiritual piece, looking at the looking at the doula role. When I look over, and I was trying to share this with people, when we started the committee, we had like 7 areas. I'm going to see if I can actually put these into the chat, and then take a second to kind of see where we're at with each of them. I think that may be helpful as we're moving ahead. So give me a second here. Okay. Okay. So everyone see this okay in the chat here? So these are really the 7 things that we looked at here, and I'm just putting this up for the group to talk about, so to see whether we think there's more information that we need. First was establishing definition of scope for end of life criteria. I think we've gotten a lot of feedback on that. A lot of what we've been focusing on here is the therapeutic team development. So I think we're getting good information here. The inclusion of family and caregivers, we've talked some about. So I think one area we haven't had a lot on here is sites of end of life care. And I'm hoping some of that will get covered, when we have talk of hospice. Jennifer Johnson up with Red Willow to cover that area there. And then the other is development of psilocybin assisted therapy end of life care plans. That may be helped by James Brown giving us some information about dosing intervals there. But I just wanted to kind of open the discussion to see if people think that there are other things that we want to make sure that we're covering before we, in the next couple of months, or just any comments on any of these. If not, y'all get half hour of your life back, and we're all set to meet next on April 3rd.
Okay, well, thank you, everybody. We appreciate you all being here. And again, thank you to Danielle for the presentation. Oh, we do have a hand
you
up
have a
now.
hand up there. Yeah, Erica. I have enabled your microphone. Please begin when ready.
Are you able to hear me?
Yes.
Okay, great. Yeah, I just wanted to introduce myself. I'm the lead faculty on a team at New Mexico State University School of Social Work and Public Health Department that received, we're going to be part of the faculty fellows for the USONA UPEP cohort for this 2026. And so they're helping us to design curriculum related to psychedelics. And we're really excited for that and hope that we could maybe be a hub for education broadly for all professionals that are engaged in this, but specifically for social work. No,
Erica,
that's
this
all.
is Larry.
Yeah.
I'm really familiar with the program. I think it's amazing that you guys have 3 people down there and resources. I've heard they're actually expanding that program to include clinicians at different sites too. So it seems like a great opportunity to really to do that. So I'm just giving my personal excitement about it.
Yeah, just let me know if I can be of support in any way, and I look forward to working with all of you.
If anyone else has any questions, please raise your hand and I'll be able to unmute yourself right away. I believe that concludes it. I'll pass over back to you, Lawrence. Go ahead.
So just if people want to make a note, so we'll have April 3rd will be a meeting, same time, and Friday, April 17th, same time zone, and then the April 23rd will be the blended meeting that will be in Albuquerque at the Bioscience Center, and the address will get listed online. That'll be from 1 to 4, and there'll also be a virtual. So those are our meetings for the next for April. So April's a busy month. We actually have three meetings set up, and the hope is that we'll be in a good position to start working on more developing some recommendations. Thanks, everybody. Have a great couple weeks, and see everybody on April 3rd.
Thank you again, everybody. And just so everyone knows, I did just post all of the next several meetings into the chat as well, if you want to go and register for those now. Thank you. Have a great weekend, everyone.
Okay. Thanks, Dominic.
Thank you.